Today we'll be doing something a bit different. We'll be continuing from the last lectures. What did we discuss last time? We introduced the concept of pharmacology, and then also we went on to talk about the routes of administrations, and then we talked about the 6 rights of a pharmacist. So make sure you go through those and internalize those concepts before proceeding to this concept. So today we'll be talking about pharmacokinetics, or pharmacokinetics as most people like to pronounce them. So when we talk about pharmacokinetics, I think the best and easiest way to think of pharmacokinetics is to think of them as being what essentially the body is doing to the drug, or the changes that occur in the changes that occur to the drug because of the influence of the body. That's what we're referring to when we talk about pharmacokinetics. So how many pharmacokinetic parameters are there? So the pharmacokinetic parameters will usually depend on the route of administration. If you remember, we discussed the local routes, we discussed the systemic routes. We said under systemic routes, we have enteral, we have parenteral, and all that stuff you'll find in the other video. But then what I want to stress is that the pharmacokinetic parameters depend on the route of administration that you choose. So suppose we look at the oral route of administration. If you take a drug orally, there will be 5 pharmacokinetic parameters. So the first one will be liberation. First, that drug will have to be liberated from that formulation, from the dosage form that you've used, right? So if, for example, let's say that's a capsule, what will happen is that that drug will first have to dissolve before anything could happen, right? We call that liberation. This one only happens for the oral route most of the times, right? And then of course you could also see it in BACO, but usually BACO is they usually use liquids or fluid formulations. But okay, typically you see this one for oral administration. And then you have these other 4 pharmacokinetic parameters that span throughout. They cover all the other routes of administration. So which ones are these? So just so you're getting me clearly, I'm saying the pharmacokinetic parameters for the oral route will be LADME, right? LADME, which is liberation, administration, distribution, metabolism, and excretion. But for all other routes of administration, we just say ADME, which is absorption, distribution, metabolism, and excretion. Okay, yeah, so that's pretty much it. So now what does it mean when we say when we say absorption? So you need to remember, when we say absorption, what we mean exactly, we're saying this is the movement of that drug from the site of administration all the way into systemic circulation, which is the blood stream. So when we say that, that's what we mean when we say absorption. So you need to remember that. Then what do we mean when we say distribution? So you need to remember, when we say distribution, what essentially we're saying the movement of that drug from the bloodstream now all the way to where? To the site of action. That's a very important one. So absorption, we're moving from the site of administration all the way into systemic circulation, the bloodstream. Distribution, we're moving all the way from the bloodstream now to the site of action. And then when we talk about metabolism, metabolism is referring to how that drug is biotransformed, right? So what is to biotransform? It means how that drug is changed. Usually that drug will be modified in a way. You add functional groups to that drug in order to make that drug more interactive with the biological system, in order to make it more water soluble, in order to make it easier to excrete. We'll talk about that in detail. So we call that process biotransformation. So the primary area where drugs are biotransformed is the liver, right? And then excretion. Excretion is the last one. When we talk about excretion, we're talking about the removal of the drug. It's literally what it sounds like, right? So we're talking about how we're going to remove this drug from the body. So usually we remove this drug through urine, through sweat, through stool. There are so many other ways we could remove drugs. For example, there are some drugs that are released through breast milk. So this is why, as a pharmacist, you need to be educated. You need to be able to know which drugs are contraindicated in people who are breastfeeding. Why? Because the metabolites could be excreted through the milk, and then if that particular mother is breastfeeding, the child will be taking in those drugs. I think an example I can give you as at now, we'll talk about it later, is H1 blockers. So when I say H1 blockers, I mean antihistamines. For example, mostly first gen, even second gen, are excreted through breast milk. So we mean things like chlorpheniramine, which is Piriton, right? We mean things like diphenhydramine, all those types of antihistamines. I'll give you a good mnemonic to remember all your first and second gen antihistamines in the future. So you need to remember, how do drugs actually access a biological system? In this case, we're talking about your body. So they usually access your body through how many ways? They access it through 4 ways. These ones are the 4 ways here. So we have passive diffusion, facilitated diffusion, active transport, and endocytosis. Sometimes endocytosis is sometimes called bulk transport. So don't get shocked when you see that in a pharmacology book. So what is passive diffusion? Passive diffusion is exactly what you're thinking right now. That's assuming you're thinking of simple diffusion. Anyway, so it's the movement of substances from a region of high concentration all the way to a region of low concentration down a concentration gradient, right? So that's, we call that passive diffusion. So drugs, examples of drugs that use passive diffusion, please do not memorize these drugs. I'm just using them for context, right? So you can at least associate something with the process. But for now, do not memorize these drugs. I'll show you which drugs you should know at this point in life, right? But then passive diffusion examples of drugs, we have ethanol. Ethanol, very important. For those who don't know, when we say ethanol, we're talking about the actual alcohol, right? It uses passive diffusion. We're talking about drugs like diazepam, of which diazepam, you will learn in the future, it's a benzodiazepam, right? We'll talk about it in the future. It's used for seizures, and I've also seen it used in maybe organophosphate poisoning when someone is seizing, right? Okay, typically we're saying we use this one in seizures when someone is convulsing, right? And then we have facilitated diffusion. Facilitated diffusion, do not memorize these drugs again. We have acyclovir. So acyclovir is an antiviral. Another trick, you need to know that whenever you see a VA in the drug, right? At any point in life, when you see a VA, by VA, I mean this, the VIR. Know that that drug is an antiviral drug. Usually the VAR will be at the end. It could be in the middle, but just know that that would be an antiviral drug. That's what I could tell you for now, right? And then we have metformin. Metformin is the first line drug in the treatment of diabetes, right? Specifically diabetes type 2. Okay, we'll talk about this in the future. We have active transport. These drugs, we have digoxin. I'll tell you in the future how digoxin works. We have omeprazole, which is a proton pump inhibitor, empagliflozin, which is also used in diabetes type 2. We'll talk about this one. Furosemide, which is a loop diuretic. All these use active transport. Don't memorize the drugs. Again, I emphasize. And then endocytosis or bulk transport, we have usually big drugs, right? Or yeah, big drugs are usually taking this route. So we have drugs such as B12. Who knows what's the other name of B12? Yeah, I don't know if anyone has been able to produce this, but it's also called cyanocobalamin, right? Or sometimes they call it cobalamin, right? B12. So we usually take this one whenever someone has a deficiency. When someone has a deficiency of B12, they usually develop pernicious anemia. I'm sure you remember this one from your biochemistry. And so in the treatment of pernicious anemia, we give vitamin B12. And then it's so big that it's usually taken in by endocytosis. The cell just has to kind of form this indent on the membrane, and then like engulf the B12 and then take it in like that. We call that process endocytosis. And then we have trastuzumab. Trastuzumab is an example of a monoclonal antibody. Yeah, so this one you use it in cancer. I'll tell you about it in the future in more detail. So, what am I doing? So let's talk about some of the things that can affect absorption. We said absorption is the movement of the drug from the site of administration all the way to the bloodstream. So I'm moving from the site of administration to the bloodstream. Now, what are the factors that can affect? So there are some factors that depend on the patient. We call these patient factors. There are formulation factors, there are drug factors. So the patient factors will include things like gastric emptying rate. Let me explain this one. Suppose an individual has constipation, for example. If that individual has constipation, what do you expect? You expect absorption to be more. Reason why you expect absorption to be more: the drug has more contact time with the mucosa of the GIT, right? So it can readily absorb. Then if someone had, let's say, a condition such as diarrhea, what do you expect? The drug has less contact time, and so you expect less absorption. Surface area. Surface area is usually referring to the intrinsic health of the gastric mucosa. Suppose an individual has, let's say, celiac disease or something. You know, they have some sort of pathology that makes maybe reduced the number of cilia. There is less surface area, and so you expect less absorption. GIT disease, same idea, right? If they have some disease like inflammatory bowel disease or Crohn's disease, or you know, any form of disease that maybe that hinders the normal physiology of the gastrointestinal system, you expect less absorption. Let's talk about formulation factors. Formulation factors are factors that depend on the actual formulation, meaning how they made the drug, right? One, excipients. Sometimes the absorption depends on the excipients you use. What are excipients? You know, whenever you make a drug, or let me not say a drug, whenever you make a medicine, it has two things. We have the API, which is the active pharmaceutical ingredient, and then we also have the excipients. I think you learned this in pharmaceutics, right? So the API is the actual part of that drug that's going to elicit the action, right? We call that the API. And then the excipients, what are excipients? Excipients are referring to the other things you add on to the drug in order to carry it. So excipients could be sweeteners. They could help maybe with the binding, or the protein binding. They could help with the color. They could have preservative action. They could have, you know, they could help with the taste. Maybe they could be sweeteners. They could help with the, you know, those are things that just help with the formulation. So the excipients you use also affect the absorption. And then the dissolution rate. So the dissolution rate, what are we saying there? Depending on the dosage form, right? Different dosage forms dissolve differently. For example, a capsule dissolves much slower than an let's say a fluid, or let's say a liquid formulation, right? So a liquid formulation therefore will have more absorption, right? So let's talk about drug factors, the molecular weight. The smaller the molecular weight, the more the absorption. Lipophilicity, the more lipophilic that drug is, the easier it is for it to cross biological membranes. And so if it can cross biological membranes, what do you expect? You expect good absorption. The pKa, what is this referring to? This is the dissociation constant. The pKa is referring to at what pH, determines what pH the drug will most preferably absorb in. So for example, if the pKa of that particular drug is close to the pH of that environment, absorption is minimal, or is maximal, sorry, it's better. For example, let's say some drug had a pKa of, let's say, 3. Of course, I can't think of any drug with a pKa of 3, but I'll just use that, right? And then let's say that drug is to absorb in the duodenum, of which the duodenum is slightly acidic, right? let's say for conceptual purposes, let's say the pH of the duodenum is 2, right? So what do we expect? When that drug reaches the duodenum, it will easily absorb, right? Because the pKa and the pH are roughly the same. That's another way of thinking about pKa without getting into the intricacies of the matter, right? GIT stability. Certain drugs are not GI stable. I'm sure you learned this in pharmaceutics, your first lecture. You talked about some of the problems you face and then some of the solutions. One of the problems was that certain drugs are not GI stable. I think the most famous example they give is Pen-G, right? Penicillin G. So penicillin G is an antibiotic specifically. It's a penicillin. But then one thing you'll be able to see, it has this one downside. Actually, two downsides. Okay, but the major downside is that it is not acid stable. And then also it's susceptible to penicillin. We'll talk about that some other day. But then what happens when you take in Pen-G? That acid could deactivate the enzyme. It could break the beta-lactamase ring, render it useless, right? Another example of a drug that's not stable is insulin, right? So insulin is a peptide hormone. Whenever you take insulin orally, this is why you will never ever find an insulin tablet. What is the reason for that? If you were to take insulin orally, what would you expect? You would expect that that insulin would be degraded by the proteases because it's peptide in nature, right? Yeah, so let's move to the next concept. What am I doing? Yeah, so let's move to the next concept. So now, these are some of the factors. So pH or ionization constant, we explained what this means. Another thing maybe that I want to add on, you need to remember that pH is a very important parameter that affects absorption. Another way to look at it would be to think about this. So suppose we had this particular species. Okay, let me do it again. Suppose we had something like this. Suppose we had something like this. This is representing any form of acid, right? Where this acid can ionize, right? And when this acid ionizes, you form two things. You form this, and you also form this, right? So now, what's my point here? I'm saying pH is a very, 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 I stress this, very important parameter that affects absorption. Why am I saying this? I'm saying this because suppose you made a drug. If that drug was acidic and if that drug was basic, it will have a different absorption profile. So let's suppose we had a drug like this, HA. When I say A is representing the entire drug, no matter how complex it is. And then the H is representing a proton, right? So this is the acid, right? But then now, the thing I want to bring to your attention is this. All drugs are either weak bases or weak acids. I emphasize that point. You never see a drug that will be a strong acid or a strong base. What is the reason for that? So the reason is quite simple. If you had a drug that was a strong acid, by Arrhenius' definition, how do we define an acid? An acid is something that when you put it in aqueous media, it dissociates and then gives you hydrogen ions, gives you protons or hydrogen ions as the only positively charged ions. If that thing was a strong acid, everything would dissociate, right? And then this form here, that is dissociated here, is not lipid soluble. It's not able to cross biological membranes. For this reason, drugs are never strong acids and are never strong bases. For this, this is a very important concept. Okay, another thing that you would see, if it was a strong acid, it would most likely destroy your insides. But it's also important to look at that explanation. Well, okay, yeah. So now the thing I expect you to know is that a drug will never be a strong acid and it will never be a strong base. It needs to be a weak acid or a weak base. Why is that advantageous? Weak acids and weak bases exist in a state of equilibrium where they are in this state of existing between this form here and that form and that form there, right? They're in that state of equilibrium. So this here is referring to the form that is this here is referring to the form that is not capable of crossing biological membranes, the A to the negative. Reason, because it is charged. Charged species do not cross membranes. And then this one can easily cross membranes. So now, what am I saying? I need you to remember there's a law called LECHATELIERS principle. What does LECHATELIERS principle say? So let me show it to you properly. There. So there's LECHATELIERS principle. So LECHATELIERS principle says that whenever a system is in dynamic equilibrium, right, any form of change you impose on that system will result in a shift in that system in order for it to restore the system back to equilibrium. What are we trying to say? I think, let me explain this one. I hope this video is not too long. Okay, but anyway, so suppose you had something like this. Let me give you a thought analogy to associate with this. So I'll draw on these words. So suppose you had something that looked like this. You had a very simple system that looked like this, right? Let's say this was two containers connected by a pipe. Suppose I filled these containers up to that level. I just filled one side. Honestly, conceptually speaking, what do you expect to happen the other side? So if you are thinking the way I expect you to think, most likely you said they'll be at the same level, and that makes lots of sense, mostly because there's a pipe here and it's connecting, so these systems will be at the same level. These systems are in a state of what? Static equilibrium. I'm sure you remember your physics. But then suppose for some reason I drain out one side and then the liquid is up to that level. What do you expect on the other side? Do you expect the level to still be the same? No. What will happen is that these two sides will find the dialogue. They'll be at the same height. Are we getting the concept? That's an example of the LECHATELIERS principle. So before I disturbed the system, it was in a state of equilibrium, right? Any change I made on the system had some changes within itself in order to return the system back to equilibrium. That's the LECHATELIERS principle in simple terms, right? So that's what happens. So now, let me start with the acid here. So you have this acid here. Let's start with this. When you have this acid here, what you're doing is this acid is dissociating into protons and into the charged form of the drug, right? Now, suppose I put this drug in acidic media. In acidic media, what do you find? You find a lot of protons. If I put it in protons, already the environment has too many protons. So do you think it will want to be in a form that has too many protons? No. It will want to shift in order to restore the system back to equilibrium. It will want there to be less protons. And so the equilibrium will shift this way. I hope that's making sense. So if you put an acidic drug in acidic media, there is already too many protons, and so it will not favor this form of the drug. It will favor this form. So the key thing I need you to remember is acidic drugs absorb well in acidic media. That's the key thing I want you to get from everything I just explained. You could forget most of what I just said, but remember that acidic drugs absorb well in acidic media. Let's look at this situation. So suppose you had a basic drug reacting with water here, and then you're forming hydroxide ions, and then this ion, this here, should be positively charged. Yeah, like that. So now, if you have a basic drug like this, suppose you get that basic drug and then you put that basic drug in basic media. In basic media, what do you expect? You expect some OH ions, right? So there are so many hydroxide ions. And so which side do you expect the equilibrium to shift? So if you're listening, you're able to tell that equilibrium will shift this way. And then when the equilibrium shifts this way, it's favoring the uncharged form of the drug, which can easily cross. So what's the conclusion there? We're saying that basic drugs absorb well in basic media. That's the thing I want you to remember. Very important concept. Other things that affect absorption, blood supply to that particular tissue. So the better the blood supply, or the more the perfusion to that particular tissue, the more the absorption. That is quite obvious, I think. So whenever you're doing certain activities like exercise, for example, what happens is that you're activating your sympathetic nervous system. When you activate your sympathetic nervous system, autonomic nervous system goes down. So another thing, whenever your sympathetic nervous system is activated, we'll talk about this in the next couple of lectures. One thing you'll be able to see when your sympathetic nervous system is activated, blood supply to certain tissues is withdrawn. One of those tissues is the GIT. You cause vasoconstriction, and then you reduce the perfusion to the GIT, right? When you do that, what are you doing? You're reducing the blood supply. When you reduce the blood supply, absorption is reduced. So you're not absorbing food when you're exercising, when you're running, when you're fighting, right? That's another thing to take note of. Or when you undergo some sort of shock. So what is shock? Shock is not really what it sounds like, right? So in pathology, you learn that shock means reduction, or it's when there's less perfusion to a particular tissue. It could be due to so many reasons. I'll talk about it in the future. So now, surface area, we discussed this one. We said if the microvilli are less, or if the villi are less, absorption is also less. Contact time, if you have diarrhea, we expect less absorption. If you have constipation, we expect more absorption. Bioavailability. Bioavailability refers to the fraction of drug that will reach systemic circulation. This one is a very important one. I think it's also important to look at things like this. So suppose this was, okay, let me draw again. So suppose this was showing your intestines, right? Whenever you take in your drug, what do you expect? That drug, you want that drug to enter systemic circulation, but it does not necessarily directly enter systemic circulation. What happens is that there is a vein, right? This vein connects to a structure. This structure is called the liver, right? So now, what is the name of this vein? This vein is called the hepatic portal vein. The hepatic portal vein, right? The hepatic portal vein. So whenever you take in food or anything, so if you take in the drug orally, it will absorb through the villi and then enter the hepatic portal vein all the way to the liver. Then from the liver, that's when now it can enter systemic circulation, right? Now, the key thing I'm trying to say is this. Whenever you take in a particular amount of drugs, let's say you took in 20 milligrams of drug, right? Yeah, I need to get a better writing too. Suppose you took in like 20 milligrams of drug. Because that drug first passes the liver, you do not expect to have 20 milligrams in systemic circulation. No, you expect it to be less because some of that drug will be biotransformed in the liver, right? And so the fraction of drug that enters systemic circulation is what we're referring to when we say the bioavailability. So if we say the bioavailability is 20%, what we mean is that only 20% of that drug has reached systemic circulation. If we say the bioavailability is 50%, only half of that drug has reached systemic circulation. So let's talk about, so we talked about pH, we discussed this very well. And then these are examples of weak acids, these are examples of weak bases. So the key thing I want you to know there, usually whenever you see a drug ending in INE, it's showing that drug is an alkaloid, and alkaloids are most of the times are basic in nature. So whenever you see a drug ending like morphine, quinine, codeine, pilocarpine, atropine, mascarin, all those types of drugs are basic in nature. So that's just the key thing you can look at when you see this INE. And then most of the times the other drugs will be acidic, although not really always. But don't memorize these drugs, I just use them for context.